All right, today we're tackling a big one, something you're absolutely going to see, whether it's on an exam or in your clinical rotations, chronic bronchitis. So let's just dive right in. So picture this, because it's a super common scenario. A patient, probably a longtime smoker, walks into the clinic. They've got this nagging cough they just can't shake, and they're bringing up sputum, phlegm, every single day. Now, your first instinct might be to just write it off as a smoker's cough, right? But we got to be careful because this classic story is a huge red flag for something more serious. And that something is chronic bronchitis. Now, what's really interesting here, and super high yield for exams, is the definition. It's a clinical diagnosis. That means you don't need a fancy lab test or an x-ray to nail it down. It's all about the patient's story. You're listening for that key phrase, a productive cough for at least 3 months out of the year for 2 years straight. You hear that? You should be thinking chronic bronchitis. And it's really important to know where this disease lives, kind of its family tree. Chronic bronchitis is one of the major subtypes of COPD. That's chronic obstructive pulmonary disease. It's basically one half of the classic COPD duo, with the other being emphysema. Okay, so here's our game plan. We'll start with the basics, then get into the nitty-gritty of how it happens, what the classic patient looks like, how you diagnose it, and finally, what we can do about it. All right, first up, the pathological cascade. Let's get under the hood and see what's actually going on inside the lungs that causes all this trouble. Seeing it side by side makes it so clear. On one side, you have a healthy airway. It's nice and open, with just a thin little layer of mucus to keep things moving. But then you look at the bronchitic airway, wow. It's a totally different story. The glands that make mucus have swollen up, you've got these thick plugs of gunk clogging the lumen, and the whole airway is just narrowed. It's like trying to breathe through a clogged straw. And this whole mess doesn't just pop up out of nowhere, right? It's a cascade, a chain reaction. Step 1 is chronic irritation, and 9 times out of 10, that means cigarette smoke or pollutants. That constant irritation triggers step 2, changes at the cellular level, and all of that leads to step 3, the actual physical blockage of the airway. So let's zoom in on those cellular changes. The lining of the airway is basically trying to protect itself from that constant irritation, but it kind of overdoes it. The mucus glands, they get bigger. That's hypertrophy. And the number of these little mucus factories called goblet cells just explodes. The end result of all this is the absolute hallmark of chronic bronchitis, mucus hypersecretion. The lungs are just churning out way, way too much mucus. So what does all that gunk and narrowing actually do? Well, the bottom line is simple, and it's pretty severe. It makes it incredibly difficult to get air in and out. That's reduced airflow. And even more importantly, it messes up the whole reason we have lungs in the first place, gas exchange. The body just can't get the oxygen it needs or get rid of the carbon dioxide it doesn't. Okay, so this mess inside the lungs creates a very specific type of patient presentation. You've probably heard the term before. It's the classic blue bloater phenotype. And that name, blue bloater, is actually a perfect description of what you see. The symptoms, sure, they're what you'd expect. That chronic cough, shortness of breath, maybe some wheezing. But the signs are where the name comes from. The blue part, that's cyanosis, a bluish tint to the lips and skin because of low oxygen. And the bloater part? That refers to the fact these patients are often overweight and have peripheral edema, swelling in their legs and ankles. But why do they look this way? What's the physiology? Well, it all ties back to that messed up gas exchange we were just talking about. Their body is constantly struggling with low oxygen, that's chronic hypoxia, and high carbon dioxide, or hypercapnia. The hypoxia is what gives them that bluish color, the blue. And the body's reaction to all this stress, especially on the heart, can cause fluid to back up, leading to that swelling, the bloat. See, it's a straight line from the cellular level right to what you see at the bedside. Okay, so you see this patient, you're thinking blue bloater. How do you actually lock in that diagnosis? Let's talk about the key findings. All right, we've got a few key tests in our toolbox. First, pulmonary function tests, or PFTs. You're going to see classic signs of obstruction, especially a low FEV1. That's how much air they can blow out in 1 second. The FEV1 over FVC ratio will also be down. Next, you can check an arterial blood gas, or an ABG. This is going to show you exactly what's happening in the blood, low oxygen, or hypoxemia, and high CO2, hypercapnia.
And finally, a chest x-ray might not be diagnostic on its own, but it can show clues, like thickened airway walls, which we call increased bronchovascular markings.
All right, we've made the diagnosis. Now the big question is, what do we do about it? Let's move on to management and treatment strategies. And look, if you take away only one thing about treatment, let it be this. The single most important, most effective, most critical step is smoking cessation. We have to stop that chronic irritation. For almost every single patient, that means quitting smoking. Seriously, nothing else we do will have as big of an impact. It's number one with a bullet. Okay, so after we've hammered home the smoking cessation point, we move on to medications. We use things called bronchodilators, like beta agonists and anticholinergics, to help open up those narrowed airways. We can also use corticosteroids to calm down some of that inflammation. And for patients who are really hypoxic, supplemental oxygen therapy isn't just a comfort measure, it's a lifeline. But there is a massive, super important warning that comes with oxygen therapy. It's a classic exam question for a reason. See, in a healthy person, the brain tells us to breathe when our CO2 levels get high. But in these chronic bronchitis patients, their body has gotten used to high CO2, so that sensor is basically broken. Instead, their body relies on low oxygen levels as the signal to breathe. We call this their hypoxic respiratory drive. So what happens if you blast them with too much oxygen? You take away their only signal to breathe. You can actually make them stop breathing. That's why we have to be so careful and give them just enough oxygen, but not too much. All right, let's do a super quick, rapid recap. Definition: a productive cough for 3 months a year for 2 years straight. Number one cause: smoking. The main problem inside: mucus hypersecretion leading to airway obstruction. The classic patient: the blue bloater who's cyanotic and maybe has some edema. And treatment: stop smoking. Then bronchodilators and very careful use of oxygen. Got it? So now you've got a really solid handle on chronic bronchitis. But it leaves us with a cliffhanger, doesn't it? We've talked all about this disease of the airways, so how is it different from its COPD sibling, emphysema, which is a disease of the air sacs, the alveoli? Well, that's a great question, and one we'll tackle next time. Thanks for joining me.